I want to thank the organizer for this great initiative. I'm excited to participate, also online only, at Third International DADA 2 Conference. Thank you for inviting me and giving the opportunity to present our cohort of DADA 2 patients. The year of this Congress is special. At 25 years ago, an Israeli story of DADA 2 started with presentation of these two children to Dr. Navon and to Dr. Padeh. They, and later their different family members, were diagnosed as panvasculitis, all of them of Georgian Jewish origin, and we name it Georgian polyarteritis nodosa, as we understood that this is a new entity, the first autosomal recessive vasculitis. At 2011 genetic labs of Efrat Levi Lahat at Jerusalem and Marie Claire King in University of Washington sequenced the whole exome of patients, and the mutation, then it was called CECR1 gene, was found. Of 246 unrelated Georgian Jewish controls, 25 were heterozygous, yielding an estimated carrier frequency of 10% in this population. This was published 6 years ago in New England Journal of Medicine with a study from our friends from NIH. During the next 2 decades, many similar patients presented to different medical centers in Israel. I will present now a cohort of 40 DADA 2 patients followed at 10 Israeli medical centers. A few more patients were not included in this study. During the last years, despite the decrease of intercommunity marriages of Georgian Jews, many new patients were diagnosed with DADA 2. This happened to better awareness of the disease, and the proportion of non-Georgian Jewish patients increased. Today, Arab patients constitute almost 20% of the cohort, and our study will include 28 familial and 12 simplex patients. The mean age of disease onset was extremely variable from 2 months to almost 60 years, and in most cases, 75%, the first manifestation was at childhood before the age of 10, and in 6 children, even disease started before age of 1 year. All Georgian Jewish patients were homozygous to 47R mutation. One Jewish patient was compound heterozygote. Interestingly, 3 Arab patients carried the exact same homozygous mutation as the Jewish patient, and 2 others had homozygous mutation, the same codon like a Georgian mutation, but with a different nucleotide change. So the G47R mutation is a founder mutation in Georgian Jews, but it was interesting to note that other patients had mutation actually at the same hotspot of the gene. Here you can see all common clinical manifestations, mainly skin, systemic and neurologic. You can see the dominating colors. All our patients had dermatologic involvement, with livedo reticularis being the most prominent in almost 80% of our patients. Sometimes it was the sole manifestation. Palpable nodules, purpura, different exanthems were prevalent as well. Recalcitrant skin ulcers, as you can see here, were common, and in some patients, they were the most prominent feature. They were recurrent and healed very slowly. Probably more undiagnosed patients with such ulcers are treated in dermatologic clinic. One such patient was added recently to our cohort. Different pathologic findings were observed at skin biopsies. Necrotizing vasculitis, characteristic of polyarteritis nodosa, was found in specimen from 12 patients, and other findings were leukocytoclastic and small vessel vasculitis. Visceral involvement was of great importance, and more than half of our cohort had gastrointestinal tract symptoms, mainly chronic or recurrent abdominal pain, diarrhea, some of them diagnosed with inflammatory bowel disease, and 5 patients even had intestinal perforations and underwent bowel resection. A third of patients had renal hypertension, often difficult to control. Neurologic disease, which occurred in many patients, affected the CNS with seizures, strokes, usually ischemic, and various degrees of coma. Significant part of our patients had cranial and peripheral nerve pulses. Fever, musculoskeletal complaints were common at presentation. Overall, the clinical picture was extremely variable, even within the same family, ranging from skin disease only in 4 patients to severe multisystem vasculitis involving 1 and more organs. In 6 of them, it was fatal, and we have evidence of continuous disease up to 55 years, of total more than 800 patient years. In addition, we considered 1 or more of these manifestations as indicator of severity. It was striking how the age of the onset predicted the severity of the disease. Almost 80% of the youngest had severe multisystem disease, and in addition to the age of onset, the presentation predicted severity as well. So the treatment. Initially, we treated this patient with medication used in other rheumatologic diseases and vasculitis. Nevertheless, about 20 years ago, our most severe patient with extremity intestinal necrosis deteriorated despite maximal immunosuppressive treatment. And in this desperate situation, Dr. Navon and team dared to try the new biologic treatment then, TNF blockade. Despite not understanding the action, the effect was miraculous within a day. Since then, a half of our patients received and receiving anti-TNF treatment, and recently it is the first line of treatment in more severe patients. Most patients are on continuous anti-TNF treatment for many years. Looking at our 40 patients, you can see here, 6 died, 6 are in complete remission without any treatment. No one of our 6 diet patients had an opportunity for continuous anti-TNF therapy. At least 3 DADA2 patients, in at least 3 DADA2 and not COVID, was the defined cause of their death. So DADA2 has many faces. Our cohort, who I presented, they are vasculitis patients, but in purely hematological phenotype, there is no vasculitis, and indeed anti-TNF treatment is not effective. Coming back to our cohort, I wish to underline that DADA2 was the first monogenic vasculitis belonging to a growing tribe of autoinflammatory diseases. Unlike the well-known polyarteritis nodosa, it is genetic and affects very young children. Most of our patients are of Georgian Jewish, but not only, origin. Their disease is caused by founder mutation, and anti-TNF treatment is very effective and life-saving. Our future challenges are to define the disease score, disease severity score, and outcome predictors, to understand treatment algorithms, and to investigate the issue of the gene penetrance. And finally, I wish to thank all contributors and our patients and their families, and hope to meet you all in person at the next DADA2 conference. Thank you.